Good afternoon, everybody. My name is Carlos Del Rio, and I'm a professor of medicine at Emory University School of Medicine. And I'm happy today to be joined by two colleagues, Bonnie or Yvonne Maldonado from Stanford University and Peter Chin Hong from University of California at San Francisco. And we're here to discuss our urgent updates and urgent viral outbreaks. And there's a lot happening, and there's a lot that we're paying attention to, all the way from measles to respiratory viruses to viral hepatitis, and this is a great opportunity for us to really have a conversation of where things are, what's going on, and what do we as clinicians need to be aware of. So, welcome, Bonnie, welcome, Peter, and let's get started. It's early May. What's going on with measles? Bonnie, maybe you can set the stage of where we are. We passed 1,000 cases nationally. I think we're going to be losing our eradication accreditation pretty soon.
Well, let's hope not. So there are a number. So as you all know, we're experiencing a measles epidemic. I would say we're close to epidemic. It's not endemic yet. We have over 1,000 cases. We are reaching one of the highest number of cases we had was just over 1,200 cases in 2019. Since the year 2000. So we're getting close to that number already, and it's only the middle of the year. We have outbreaks in 30 different states, or cases in 30 different states. The vast majority, over 90%, are outbreak related. So they're not individual travel related cases. And many of these cases are in young children. They're being hospitalized, and we've had 3 deaths. What we're seeing really here, as all of you probably know, is the fact that we are experiencing under-vaccination around the world, probably as a result of COVID restrictions and an inability to get children back to schedules. 90%, 98%, 96% of the cases in the US are unvaccinated cases, completely unvaccinated. There are cases in very few handfuls of people who are non-responders who had maybe 1 or 2 doses of vaccine, but we know that it's really under vaccination and the fact that there are outbreaks around the world. This is a fully preventable disease. We could eradicate measles, and we were on the brink of that a few years ago, and now we are scheduled to see a resurgence of measles.
So, Peter, you and I take care of adults, and I'm getting a lot of questions from patients, from colleagues, from family members. What do I do? Do I need a new booster? I'm 50 years old. I'm 60 years old. I'm 70 years old. I probably got measles as a kid, but the vaccine I got probably was the old vaccine. What do I do now? What are you telling people?
Well, I think riffing off what Bonnie just said, probably the lowest hanging fruit is those who haven't had any immunizations. And on the other extreme, people who were born before 1957 typically don't have anything to worry about in general, because at that point, they would have been naturally exposed, and that would have given them lifelong immunity. In the beginning, there are 2 things that happened. First, there was a not as effective vaccine that was used until around 67. And that is one issue. And then the second issue is there was only MMR is only given for 1 dose until maybe 1989. So to come back to the top, the lowest hanging fruit again, unvaccinated. The second group is those who have only maybe received 1 shot. You can either get your titers checked, which is probably what most people are doing these days if they're worried or traveling internationally, and then getting another shot. And then for those who might have gotten the less effective vaccine, which might have been before 68 or so, between 57 and 68, maybe getting another updated shot. So those are some of the things I think about with people. I mean, I think if we lose elimination status for measles, what I'm worried about is that with that herd immunity that we relied on, and outbreaks being extinguished or cases not really going very far, we never really had to think about HIV patients or immune compromised individuals who might have lost immunity over time. But now we have to have these kinds of conversations, which is really chilling to me in many senses.
Yeah, it's kind of complicated, so we take care of HIV. What do you do with your HIV patient?
Well, so let
30-year-old,
me,
30-year-old with low CD4 count.
so we reviewed the data on measles many, many years ago because we were doing prevention of mother to child transmission of HIV and treating people in the field. So we have most of this data from the developing world. And we know that once you reconstitute, you are able to mount a normal response and you are protected. So you're right. If it's a patient who has low CD4 counts, who may be immunosuppressed, they're not going to respond well to the vaccine. So they are really at risk in addition to other immunocompromised patients. And by the way, we've modeled in a paper that we wrote in last 3 weeks ago, in JAMA, we modeled the status of measles, rubella, polio, and diphtheria in the United States at current vaccination levels, and we will return to endemicity in 20 years. If we have a 10% reduction in vaccination, which is not outside the realm of possibility, we will see a resurgence even faster with millions and millions of cases and hundreds of cases to thousands of cases of polio and congenital rubella and diphtheria, hundreds of rubella diphtheria cases. So we're going to see a resurgence of diseases that many of us have never even seen. And so I would say for the patients, so by the way, 1963 to 1967, we only about a few thousand people got that atypical killed measles vaccine. So there aren't very many people who got that vaccine, but if you're concerned, you can get a titer or you can just get a measles shot, whatever's easier for you.
Thank
And
you,
like
Bonnie.
you said, Bonnie, I think, oh, go ahead. Sorry. Like you said, Bonnie, I think the bottom line is even though it's a live attenuated vaccine, MMR, for those who are HIV infected, and many people know this already, if your CD4 count is over 200, it is safe to get the MMR.
So Bonnie, Peter, keep on talking about how effective this vaccine is, but there is a high administrator official from HHS who says the measles vaccine is not very effective. So can you remind us about the efficacy and what do we know about the efficacy and what does it mean? And why do we hear the secretary saying that the vaccine is not effective?
Well, I can't speak for the federal government, but I can speak for myself and the data that we've seen over the decades. So measles vaccine is very safe. It's highly effective. In fact, it's one of the most effective vaccines other than the COVID in terms of efficacy. So one dose of vaccine is 95% effective in providing essentially lifelong immunity. So you may occasionally see a breakthrough case, but those are case reports in the literature. The reason we do 2 doses now since the 80s is because there was an outbreak due to under-vaccination in the US. And what we found was that there are about 5% of children who are non-responders to the first dose. If you give a second dose, that 5% of non-responders actually reduces to 2.5%. So you can give a second dose. It's really to top up those 5% of kids who don't respond. The other 95% are actually going to respond to the first dose. So a 2-dose schedule is really meant to top off our immunity to about 97, 98%. And we need about 95% immunity because the R naught, or the transmission value of measles, is very, very high. It's on the order of 12 to 15 people per infected individual. So you need to have that very high level in order to prevent ongoing transmission. Right now, we're about at 93.7%. So doesn't sound bad, but it's big enough that you start accumulating a pool of susceptibles that then can set up opportunities for outbreaks.
And Bonnie, with that average number though of little under 95%, again, to me, what's striking is that there are big pockets of under immunization, big enough so that like what is happening in West Texas happens, what happened in New York in 2019 can happen. And that's worrisome to me too, not just the average.
Yeah, and that's a big issue, right? What we know is that when we track 1 to 2 year olds, for example, there are areas where vaccination rates are as low as 20, 30, 40%. So we can clearly see not just measles, but other diseases start coming back.
Bonnie, the measles, the first dose of measles vaccine is recommended between 12 and 15 months of age. I know a lot of young mothers who have babies who are under 12 months, and they're asking, can I vaccinate my kid? Should I vaccinate my kid? What is your recommendation? What are we telling people?
I think Bonnie's
Peter, you
first.
want to answer?
Yeah,
You have
so
a-
I
you have-
think generally with vaccines
Yeah,
above
yeah.
6
So
months old-
basically, sorry. Yeah, sorry.
No, you go ahead, Bonnie. Oh, she's frozen again. So generally, we start measles at age 12 months to 15 months, but
Sorry
in
about
an
that. I
outbreak
have an
setting, you
unstable
can
connection.
start
Ready?
as
Go
young
ahead,
as
Peter.
6 months old. But then you have to restart the series at 12 months. That's the recommendation anyway. But,
Yeah.
you know, like with many vaccines, above 6 months can generally respond. But Bonnie, you can amplify that.
Yeah, sorry. So we did about 15 years worth of NIH funded research on on MMR and ontogeny of infant immune responses using measles as early as 6 months of age. And it was allowed because we do know that kids will respond to measles as early as 6 months, in some cases earlier, but you get an attenuated response. And that's really ontogenic. Primarily the T cell response is not fully mature. And so you don't get a complete response under 12 months of age. So you can get a vaccine if you're in an outbreak setting, if you're going to travel to an area where there's a lot of measles and you're worried, and you need to do this in conjunction with your provider or your public health department. But that vaccine dose doesn't count for the 2 regular doses. And by the way, we have seen dozens of cases now of SSPE or subacute sclerosing panencephalitis, which is a almost fatal, nearly universally fatal progressive disease that's related to incomplete eradication of measles, wild type measles disease of the brain. And these cases primarily occur in young children who've had measles at young ages. And it is a really devastating disease, which I hadn't seen for decades. And now we've got case reports around the country. And there was a paper written about 5 years ago with a collection of cases from this disease. So there is actually pretty progressive disease that can result from from having measles disease, contrary to what we're hearing, that the disease is great to have and let's have, the equivalent of chicken pox parties. Should not be thinking about that for measles.
So you're not recommending measles parties?
Not yet, no.
Okay.
Hopefully never.
So Peter, there was a question, okay, we had an HIV person living with HIV, CD4 count over 200, we can give them a live attenuated. What are you telling people with CD4 counts under 200?
I think that's really tough. Is it a CD4 under 200, but their viral load is undetectable and their percentage is high? Maybe they've been hospitalized. I mean, it's the same question I have with anyone like that. If they're really low T cells and you think it's real and the percentage is low also, I would be nervous at this point about giving them that live attenuated vaccine like I am for any transplant patient or anybody who's severely immune compromised. So what you do in that case, just like a baby under 6 months, is you try to make sure that the people in that person's life, in that ring around the person in their household, is is maximally protected. And of course, so that's generally. I don't know, Bonnie, if you have any other thoughts.
I personally say immune reconstitute them, right? Give them antiretroviral
Yes.
therapy,
Yeah,
and hopefully after that.
get them
That, of
reconstituted
course,
as
that-
fast as possible.
Yes.
Once you reconstitute them, boy, they really respond very well to the vaccine. So it's pretty clear from studies it happens very quickly right after they reconstitute. And we
So
actually, by the way,
could somebody tell us a little bit about vitamin A? I'm hearing a lot about vitamin A, and we should.
so
It's
vitamin
better,
A is
it seems to be
yeah,
better than the vaccine, right?
No, it's not better than, yeah, it's an adjunct. It's a supportive therapy. So we found out more about vitamin A. As you know, vitamin A has tremendous epithelial impact, right? So it prevents blindness and trachoma and other diseases. And it affects the endothelial lining of the body as well. From measles is a very endothelial based organism as well. And what we see is pneumonia, diarrheal disease, and actually the cause of death from measles in the world. So in the 90s, we had 1 million children dying of measles every year. Last year was about 107,000. So we've had a major reduction. And what the kids die of is pneumonia and diarrhea. And so what we found is that these are children who are primarily vitamin A deficient as well. So measles has an immunosuppressive effect on top of the fact that if you're malnourished, you're going to have exacerbated underlying disease like pneumonia and diarrhea. If you give vitamin A, it does improve the epithelial integrity, and then these children tend to do better. The mortality rate is much lower. And in the US, we do recommend now giving vitamin A if a child has measles, especially to prevent severe disease. Not because most of our kids in the US have sufficient levels of vitamin A, but we don't want to muck around and wait. So there are guidelines for vitamin A, but it's only an adjunct. And again, you want to prevent the disease, not treat people who are already sick. But given that somebody might be sick already, vitamin A will help reduce the risk of severe disease, but doesn't prevent it.
And just to emphasize and to remind everybody, there's no treatment for measles. So once you get admitted with measles, it's supportive care and nothing else.
Well, I just want to be, so people have done studies with ribavirin, but it doesn't work.
And definitely not inhaled steroids, right, Bonnie?
No. Oh my God. No, that would be. Yeah, this is primarily a T cell disease. So people who don't have T cells don't do well with measles. So you don't want to give steroids.
So there's a question here. You know, we have seen patients who have documentation of 2 doses of MMR vaccine, but had rubella titers checked and they're negative. In those cases, do you recommend giving a booster?
Interesting. Yeah, so the problem with the rubella test is we don't even measure titers generally. If people got MMR, the titers are not very helpful. So if somebody has a record of getting MMR, we generally don't boost them again. But if they don't know their vaccination status, I suppose it might be worthwhile for them to get another shot. So rubella titers are very different. They're an ELISA-based assay that isn't very good. So we also seem to have lifelong immunity to rubella once you've gotten 1 or 2 doses of MMR.
So let's just move on from measles and just remind everybody, vaccination is the key. And in order to control this outbreak, you have to vaccinate a lot of people. I was talking to the Secretary of Health of Mexico the other day. They did a major effort in the state of Chihuahua, where a lot of the Mennonite community is. And in the northern states of Mexico, in the last week, they vaccinated over 2 million children just because, you just have to, if you vaccinate, you're going to stop this outbreak.
Yeah, Carlos, I was just in Chihuahua for a family event, and they had 400 cases of measles. It's bleeding across the border, and there is some under vaccination, and even without under vaccination, so contagious that you still have a small pool of susceptibles, and you're going to see those cases occur. So they're going to be able to stop that pretty quickly, I think, in northern Mexico, where it's coming across the border.
And it's bleeding across the northern border too, right, with Canada and around Michigan, etc.
Well, as we have heard over and over, viruses do not understand borders. It's never stopped them. So I think it's time to move on to respiratory viruses. We have our usual 3 players of COVID-19, flu, and RSV. And a lot of questions right now of what's going to happen with COVID vaccine and with flu vaccination going forward. So what do we know about? Let's start with flu. What do we know about flu vaccination? Have we picked up the strains? Are we part of the process? Are we going to have vaccine in the fall? Do you think they're going to be this is a little bit trying to read the tea leaves, but do you think there's going to be an actual recommendation from ACIP about flu vaccination?
Well, so as you know, I'm a voting member, and we don't have all of the data yet. We weren't able to vote at the last meeting because there was a delay in having the data available to the committee to review. But we do have the strain selected, although and it apparently has been voted on by FDA and CDC. But we have to make a full recommendation, and we're having a meeting in early June, and the flu vote is on the agenda. So I'm hoping that we'll be able to review that and look at it. And I can't make I don't know what the data looks like yet, so we'll have to see. But I'm optimistic that the data looks good and that we may be able to go forward.
How about COVID? Where are we with a COVID booster? Are we going to have a new booster? Are we going to have the same booster over?
Well, this is where the discussion among the group, and I'm looking forward to a discussion with my colleagues on ACIP and with the CDC and others, because as you know, there was quite a big discussion about whether we should go to targeted versus universal dosing, whether we should go to 6 months or leave it annual. And we've gotten a lot of feedback. People really want the flexibility to get, up to every 6 months doses, to get annual boosters recommended rather than just suggested. And as you all remember, those little words make a big difference in compensation and access for people who might not have private insurance or who can't pay out of pocket. And so saying could, would, should makes a big difference. And so we'll see. We have a big discussion, but I know where I can't really talk about it now, but I know what my recommendation would be. In general, I would say that universal vaccinations for most antigens generally works better. Now, mpox might be a special case, and I love to hear what Peter and Carlos have to say. But in general, when you're talking about diseases that are annual pandemics, you don't want to restrict vaccination. You want to make sure that more people rather than less people have access, because it makes it easier in our very complex vaccine and public health system to get access. So the more access, the better. Risk-based vaccination in general doesn't really work very well.
And Bonnie, I think that's a great point because people always bring it up. And wasn't that the case with the flu vaccine? Wasn't it a risk-based vaccine before, and it didn't really work for the reasons you outlined?
Yeah,
Yeah, so
absolutely.
let's move on to RSV since you touched it, Peter. What was the major change that happened, and what are we telling our patients now around RSV?
So the major change in last year was that instead of a sort of permissive recommendation for those over 65, it was a more emphatic recommendation for those over 75. And between 65 and 75, you could do it with discussion. And the reason for that was that, the sort of like the juice was with the squeeze in terms of the risk of neurologic complications. Guillain-Barré, I think there was some data showing now it was about 8 excess cases per million. So it is there, but again, the risk benefit balance goes above the age of 75. So that's kind of the latest with RSV. Other RSV news in the last few months, which was sort of reassuring, was there was an early signal with preterm births, and Bonnie might know this data well, and that was again sort of shown that not to be true with bigger and longer term, a longer follow-up period.
Yeah, so the preterm signal, just to clarify, Peter's absolutely right, but it wasn't a statistical signal. It wasn't statistically significant. But as you know, sometimes early on with smaller numbers of cases or vaccinated populations, you might not see a signal that may become statistically significant later, but this did not hold up. There was also a very, very weak signal early on with older adults and AFib with RSV. That completely went away. So that is not another signal to worry about. So I think there were just a lot. It's a new vaccine for this population. And I think people were just trying to be cautious because we want to make sure people trust the vaccine and are willing to get it. But it's had remarkable real world effectiveness. I mean, it has really kept our RSV hospitalizations for children this last season were down 40% from last year.
And then the other,
yeah.
oh, sorry, go ahead, Bonnie.
No, and I think Peter can talk about the adults as well.
I mean, the other cool thing about RSV, which kind of surprised everyone, is that in the original cohorts, when they got the vaccine, it lasted for more than 2 years, the protection. So right now, for this last season anyway, the recommendation was that if you got it the previous year as an adult, you didn't have to get it this last season. And we'll see how long the protection lasts. And Bonnie, you can talk more about the specific indications for kids and pregnant people in the 3rd trimester.
Yeah, absolutely. So those haven't changed yet, and we'll see if those change. We don't know. I think there's still a lot of questions because we have this now. We're in the 2nd season, and we'll have to see what the data look like. We haven't seen it, but as you all know, we are giving now RSV at the end of the towards the end of the the middle to the end of the 3rd trimester because of this risk of preterm. So we'll have to revisit that. I think a lot of people were complaining or worried that, I just want to go in and get my vaccine dose. And actually, the uptake was reasonable. We think that about 50% of children, infants, newborn infants, were covered either by vaccination of their mother during pregnancy or by receiving the monoclonal antibody nirsevimab immediately postpartum. So we're gonna revisit the data and see whether we can consider expanding the use in pregnant women, as well as looking at other monoclones that may be coming down the pike. So, but really very, very great safety profile for sure. And really, so far we've gotten good real world effectiveness.
Thank you, Peter. There's a question about how frequently should we revaccinate immunocompromised patients for RSV?
It was how frequent we should
Revaccinate immunocompromised patients with RSV.
Yeah, I don't think there's great data around that. So, I think we default to the regular guidelines for RSV vaccines. It's not like the COVID vaccines where you kind of have to give in more frequent intervals early on. Right now, there's no guidance outside of the recommended periodicity.
Thank you. So Bonnie, there's a lot of, lately we've heard a lot of skepticism about we don't know about side effects of vaccines, we don't monitor them, we don't study them. A lot of people don't really know what the systems are. Could you briefly tell us about what systems are there to monitor vaccine safety?
Yeah, as with any good systems-based approach, we have redundancies in surveillance. So the FDA has a vaccine safety surveillance system. The CDC has multiple. They have VSD, which is a vaccine safety data link. They have VAERS, which is the vaccine adverse events reporting system. And then they have another system that was set up for VSafe, which was set up for COVID, and that may be sunsetted. We're not sure yet what's happening with that. And so these are systems that collect data in real time. And I think people don't understand how comprehensive these are. The problem I think that people have with it is that this is not a randomized controlled trial. These are reports that come in from everybody anywhere that you can report. I had a rash after I got a vaccine. And so you need to study the data and say, okay, let's look at you who got a vaccine compared to somebody who didn't get the vaccine to see if these rashes or whatever the effects are related to vaccine or not. And this is where we have VSD, which is a very focused group of healthcare systems around the country. And they actually look at their patient populations and compare vaccinees to non-vaccinees to see if there's really a signal there. So it's actually quite robust. They've published, I would say, hundreds of papers now, and we do this in real time. So we know that there are data that really track safety. And we don't just track new vaccines. We go back and track vaccines that have been around since the beginning of CDC efforts. So we still track diphtheria, pertussis, tetanus, and all those older vaccines that started in the, decades ago. We go back and look at pneumococcal vaccines, et cetera. So the signal measurements don't stop once a vaccine is approved, and post-marketing surveillance goes on essentially for the life of these vaccines. Although they don't do every antigen every year, they will do every antigen on a regular basis. So there's quite a bit of data. I mean, obviously, we can always do a better job, and I look forward to hearing from HHS how we can do a better job. But we definitely have redundant safety systems now, and we report those out as soon as we get any kind of signal.
Thank you. Well, let's move on to treatment of this respiratory infections, because unlike measles, we do have some treatments available. So what's new? Let's start with, like we did the last time, with flu. Peter, anything new in treatment of influenza?
Yeah, so I think, and Bonnie can comment on this, what was remarkable to me this past season is baloxavir became the darling, particularly amongst pediatricians who I was talking to. And I think what was nice for me to see is that recent New England Journal article showing that it not only can treat flu, but it was also effective at preventing transmission within households. So Bonnie, why? I guess because it's a one dose kind of situation as opposed to Tamiflu for 5 days, it's getting a lot of traction right now.
Yeah, I think oseltamivir has been around a long time, and I think people just stopped studying it because it's a generic drug now, and there's a lot of opposition to using it. I think part of it is only it has to do with operational issues, like, do I have to give it to everybody? I mean, we're talking about little children with snotty noses, and they think they have, flu, which is not just a snotty nose, but you get a kid with a fever. Are you just going to test everybody? And then if they have flu, are you going to give every baby oseltamivir? I mean, that's a big burden. So the number needed to treat is pretty high because kids tend to not have severe complications. And we also, honestly, with oseltamivir, know that the risk of reduction of disease it's very relatively mild. So you take a day off of symptoms, and it may or may not affect severity of disease. Again, number needed to treat is really important. And so people have not been enthusiastic. It is recommended for children and adults who are developing or at risk for developing severe disease. And there's, I think, the main population. And I'd be interested to hear what you think about immunocompromised individuals. But we definitely want those people with underlying disease to use oseltamivir. Baloxavir has been around a long time. And I'll tell you, from the very beginning, it was just this Cadillac drug that seemed to work really well. You only need one dose. I think the concern with baloxavir is the development of resistance. And so far, we haven't seen a big signal there. So that may be a good thing, although it hasn't been utilized as much as oseltamivir. But I would say that if you have, for an adult, I think I would love to hear your recommendations. But for kids, I think children, especially who have underlying conditions, chronic lung, heart disease, respiratory illnesses, other chronic illnesses, they should probably get treated. And I agree with you. That article looking at household transmission is really important. So demonstrating that you can reduce household transmission with baloxavir use. So,
And there was in JAMA, I think, a meta-analysis last year suggesting that oseltamivir really didn't do much to either decrease symptoms or produce household transmission. So I think enthusiasm for oseltamivir has also kind of waned over the last year or so.
agree.
COVID. Are we treating COVID patients right now? Peter, what are you doing?
I think the threshold for treating COVID as immunity increases in the population is lower for Paxlovid. Right now, I mean, I think everybody has, many people might have seen that study showing that at least in using an ecological study in Ontario, where it was only approved for people over the age of, I think it was 65, that the people right under the age of cutoff without Paxlovid did just as well as the people who got Paxlovid. But again, the sort of limitations of that was that I think it only went up to like 75. And in my personal experience and borne out by the data, the people over 75 who weren't immunized recently were the ones who were hospitalized in the US. So for me, that age group still is kind of a big question. And so my questions that I would ask the patient is, before thinking about Paxlovid, is, did you get a booster within the last year or so? And are you older or have immune compromising conditions? And again, you have to think about the drug interactions. Then I would still offer that person Paxlovid. But for everybody else, I think it's, people are less enthusiastic about it. I think we do need new antivirals. We need better retrovirals. And you said, Carlos, too, this is kind of like the AZT of agents for COVID. I think the other drug that sort of everybody was looking forward to was ensitrelvir, which in Japan and Singapore, it's been already approved, but the data hasn't been as great in the US studies. So it's kind of been stalled in FDA fast track, but it is a protease inhibitor, again, without many drug interactions, and in similar way post-COVID to prevent complications.
Well, one of the other really sad issues is that I'm actually helping with the DSMB for the active 2 and 3 trials, which are, by the way, still ongoing. It's much more difficult to accrue patients now because obviously, we've done a good job in reducing cases overall. But these are multinational studies trying to still look at different antiviral therapies and monoclonals as well. And unfortunately, the funding for a lot of these studies has been stopped or will stop soon. And we're trying to, we're hoping that there will be funding available to continue some of these trials because they're not finished yet. And whether we can still look at, predetermined outcomes may not be possible, but whether we can come up with, whether the investigators can come up with ways to redefine outcomes so that they can get some data out of these amazing studies that really started a while back. But so far, no blockbuster drug has popped up yet.
But that reminds me, Bonnie, of a great question. I'd love your opinion, Carlos's too, which is like, are we shooting ourselves in the foot with the way that you're defining what success is in these trials as population immunity increases? Therefore, the quote unquote placebo isn't really naive like in the old days when Paxlovid showed, more than 90% efficacy.
Yeah, I mean, I think as population immunity increases, the risk of severe disease significantly decreases. As you say, I think we need to be focused on a very specific population at very high risk. As you said, people over the age of 65, 70 who have not received a booster in the last 6 months. And in those people is the ones we need to look at. And then I think our outcomes of interest ought to be, severe hospitalization, severe disease, death, and duration of illness, and because those are the things that really matter to the individual.
Yeah.
But what I remind people is, if you have somebody of the age of 80 who hasn't received a recent booster, go ahead and treat them, because you need to treat them before they get severe disease. Frequently, I hear people say, "Well, I'm not going to start them on therapy because they're not too sick yet."
Yeah.
Well, if you wait until they're too sick, it's too late. You treat them to prevent them from get too sick. And I think that's an important concept to get across, that frequently, as I said, I hear over and over, well, that person didn't get treatment because my doctor said I wasn't sick enough. Well, you don't wait for somebody to be sick enough to treat them.
I think that's a great point, Carlos, because again, remember, there's a concept of falling over the cliff with COVID. And President Trump in his first term, remember, he was really sick and everyone is waiting for that. Well, they were worried or anticipating this falling over the cliff part, which happens at day 5. If you look at the original data from China, day 5 to 7. So in the beginning, somebody looks, actually, to your point, Carlos, pretty normal. So you can't really judge the need for antivirals from day 1 or 2.
And this is a disease where, we saw this all, of course, during the beginning of the pandemic, where people felt great. They said, no, I don't want to participate in trials. I feel great. And the next day they were really over the cliff. And what we found is that if you actually look at, oxygen oxygen saturation levels, if you get them to do a couple little jumps up and down, you can actually see that they're actually a little bit hypoxemic, and they don't know it yet. So starting as early as possible, that was always the goal for the trials. And I think it's true for treatment as well. We need to, people feel great until they don't, and it happens very quickly.
Hospitalized patients with COVID, are you going to remdesivir? Still using remdesivir?
Yes, remdesivir. But what I've noticed is a pattern of people not necessarily finishing their course. If they're kind of getting better already, they might finish it with Paxlovid or might just go home and be treated. Remember the early treatment for the remdesivir analog of Paxlovid for 5 days is remdesivir for 3 days. So a lot of people might come in who are older in the hospital and get 3 days of remdesivir and almost be like giving 5 days of Paxlovid with a really good efficacy rate of, close to 90%.
So let's move on to RSV. Somebody gets admitted with RSV. Let's remind people what all the available treatments we have.
None.
Nothing.
Exactly. It's nada. It's like measles, right? And that's why we really think the vaccine is wonderful, because once somebody gets hospitalized with RSV, there's nothing we can do. There's no specific treatment. And again, emphasizing the fact that we need better antivirals for many, many diseases, but we have a good vaccine. So why waste a good vaccine? And whenever I see, I see a 75-year-old hospitalized or with RSV, it's a missed opportunity for prevention. It's a failure of prevention, because we could have prevented that infection.
Well, and when you see wards of little 6-month-old babies, where you are really almost helpless, they're on oxygen, They are, getting fluids. I mean, you're really doing nothing for them, essentially. They might have secondary bacterial infections, but it's really frustrating, especially to see these little tiny babies. And many of them will wind up with long-term reactive airway disease from their disease. So it is really frustrating. I mean, it was frustrating for sure all along, but now that we have a preventive measure, we don't want to see people get sick and then have them sit in the hospital for weeks and maybe have long-term complications. So.
Little prevention goes a long way and prevents you from hospitalization. So let's move on to another preventive infection, which is making its ugly head again, and that's hepatitis A. So what do we know about hepatitis A? There's an outbreak in your neck of the woods, Peter.
Yeah, so everybody's paying attention to hepatitis A, particularly in California now, because there's been this sort of like smoldering outbreak that started off in people who are experiencing homelessness in Southern California, and now it's the wastewater is up in the first quarter of the year, and shockingly, there's been 7 deaths. So I think hepatitis A, we don't really think about it as causing a lot of deaths. So if you look at the data, it's less than 1%, so like 0.5% or 0.6%. So the fact that there's 7 deaths in LA, and first of all, and then secondly, wastewater is up. And then thirdly, which is getting people's attention, it's not in people with traditional risk factors. So not in people who are experiencing homelessness in this current outbreak now, not in people who have traveled recently to some other place, not in people who have used injection drugs. So I think what it's really showing is what people call the immunity gap. And remember, and Bonnie might have more history than I do, hepatitis A is only started as routine immunizations, and it's not even really mandated for schools, et cetera, in the late 90s. So I think 99 in California, mean 97 in other parts of the country. And then some of us have gotten Hep A, like if you've traveled, and in the old days, you used to get IVIG or something. But since the vaccine, people have gotten that, and healthcare workers. That's kind of where we are right now. If you look at the official guidance for Hep A vaccinations, it's in people immune compromised, HIV for sure, and then kids, like I mentioned. But it's kind of like wishy-washy in the other settings. So it's like, if you want it, you can get it. If you perceived at risk injection drug users, you can get it. But again, I think this is making us rethink, or possibly rethink, who should really be getting the Hep A vaccine.
Well, so hepatitis A has a very mixed history, as you said. And originally, people thought, well, it's a mild foodborne illness. It's not that big a deal. People don't die. I mean, that was classically what was said in the medical textbooks. But what's happened is we've had a shift. And even with children, the idea is, well, should we vaccinate routinely or not? It is now recommended to, get vaccine early. And that evolved, as you said, Peter, over time from just suggested. And we had it was so difficult with all the criteria. Well, you have to have 5 cases in your county before you can trigger a recommendation for vaccine. And again, targeted vaccination programs don't really work well because it's too complicated, and then not everyone gets the opportunity. So these universal recommendations in kids have really made a big difference. So there's a cohort of children who are now growing up who have vaccine, but there are some people who never got those because the recommendations were so mixed for years. There was an outbreak in San Diego County about 10 years ago. And I remember because I was a liaison to ACIP and we talked about it. And there was a group of people who were unhoused, really having, and we had a number of deaths there too, which is really concerning. It was the first time I had really recognized that hepatitis A could be involved with that. And these were people who had other underlying issues, but really there was a huge effort at the county level to really bring those people back, get them showers, get them water and soap, and places where they could, have good hygiene, because these were people who had no access to soap and water even. And then vaccination campaigns, and that really put that outbreak to rest. So I do think that better institution of more of a universal type recommendation. I know people think, well, more vaccines, but it does tend to pop up. These diseases pop up in as susceptible populations start to accumulate.
And I think if you look at the numbers, it's almost like measles again. We had 3 deaths, and if you expect like 1 death per 1,000, the number of cases is probably much bigger. But same with hepatitis A in Southern California. If you have 7 deaths and the percentage mortality is only it's supposed to be 0.5, then you might be having anywhere from 700 to 1,400 cases in the community. And with the wastewater, I think that's what people are worried about in general at the risk.
So Bonnie, you talk about, making hepatitis A vaccine more universally available, something which vaccinate more. There's a question from one of our audience participants that says, each of the vaccines looks great with particular diseases, but what about the volume of vaccines? Is it safe to give multiple vaccines, multiple number of vaccines, especially to babies? And what do we know about safety of giving 5, 6, 7 vaccinations at the same time?
Well, there have been a number of studies looking at vaccinated children over time. The Institute of Medicine did a study over 10 years ago looking at the volume of vaccine. And actually, if anything, what we've done is we've been able to demonstrate the benefits of reducing these diseases. Part of what we presented in our JAMA paper was when you give vaccinations for these just 4 antigens, you wind up reducing millions of hospitalizations and deaths and illnesses over a period of years. And yet when you look at the impact of the vaccine antigens on individuals, if anything, we've reduced the number of shots that we give to kids because we're doing more combination vaccines. And these antigens are actually very safe. The number of adjuvant, we very rarely use adjuvants in children or pregnant women, if at all. And the adjuvants are primarily given to older individuals who really need to have more of a boost to their immune response for example, for varicella. And so we also know that the number of excipients in the vaccine products has really been reduced over years. So these are very, very streamlined products. And again, the safety has been reviewed by the Institute of Medicine and other groups and have found that these are effective, and these kids are as healthier, if anything, healthier than kids who wind up being unvaccinated. And then finally, we are, as children, babies are basically an open book to the world. They are exposed to so many antigens when they're young. So this is really a drop in the bucket relative to all the other things that they're exposed to. But that's a great question. People ask that a lot.
Yeah, I think it's a very common question. Again, also allows me to remind people that we do have an MMR vaccine, which is measles, mumps, rubella, but also the certain MMRV vaccines, right, which are measles, mumps, rubella, and varicella. So frequently we're trying to give multiple vaccines at the same time. It reminds me also that I recently read a paper that said that they looked at people that got COVID and influenza vaccine, and when they got them together, actually immunity to both actually was better than when they got them separate. So
yeah, that's the combo shot that's hopefully coming out.
Yeah. So I mean, I think we increasingly are trying to figure out how to give combo immunizations, right? I mean, it's a good way. You don't want to give 7 shots if you can avoid it, So maybe 1 or 2 shots instead of 7 will make a big difference.
I mean, even with hepatitis, there's Twinrix with Hep A and Hep B, so it's kind of like a one-stop shopping too.
Yeah. And again, that's to make it easy and to make it available. And if you got somebody in for getting immunized, we'll go ahead and give them, not 1, but 2 vaccines. And I think A and B, hepatitis A and B, it's a great example of what we can do. And again, this outbreak of hepatitis A, it again reminds me of a vaccine preventable disease that we should not be seeing, that we could easily prevent, and that we have the tools available. We're simply not using them in the appropriate way. Because again, once somebody gets hospitalized or comes in sick with hepatitis A, tell us about what treatments do you have, Peter?
Yeah, so hepatitis A, we don't have good treatment. It's supportive, and we've all probably heard of cases or seen cases of people who have fulminant Hep A, and they just go very, very quickly and need liver transplantation. So
it's also important to remember, Carlos, that especially in younger people, hepatitis A is asymptomatic. So you're going to see a lot of transmission of this disease if you're not vaccinated, if you're susceptible, and you're not going to notice it until you reach that outbreak status where that high risk population starts getting sick.
I mean, and the wild thing with Hep A, which I recently remembered, is that you can be asymptomatic for 7 weeks transmit all that time and then get symptoms.
In fact, by the time you get symptomatic, by the time you develop jaundice, you're
late.
no longer infectious.
Yeah.
So, I mean, I just want to emphasize, we talked about measles, we talked about RSV, and we talked about hepatitis A, 3 diseases for which we have excellent vaccines and no available treatments. So emphasizing the benefits of prevention, right? We have excellent vaccines, we have no available treatments. Every time we see a case, we essentially have nothing in our hands as physicians to do to take care of those patients, other than, supportive care and contemplate and hope for the best, as opposed to having prevented those diseases by using vaccination. So I want to emphasize that because, again, at the end of the day, we have the tools to prevent these diseases. We don't have many tools to treat these diseases. So any other viruses that are concerning to you? I mean, I remember last
You want to
August.
talk about mpox, Peter?
Oh, we can talk about, I was going to ask you about pertussis too. So I mean,
We can
still
talk
there are
about
a few,
pertussis. Yeah, it's a bacteria, but we can get to the
Yeah,
bacteria later.
bacteria. Yeah, we can start with mpox.
Let's start with mpox.
Yeah, I think the mpox conversation is coming up again, mainly because it's pride season. I think for many of our patients and in our communities, there are, it's going to be people, potentially at risk again. And of course, every year there are new people coming in who weren't at risk before and, becoming at risk. So it's not like it's a static community. So again, it's a good reminder to think about vaccinations. And I think there's some data, a few months ago showing that as many as 3 out of 4 people haven't gotten the second shot. They might have gotten the first shot, everybody ran up to get it, but fewer people got the second shot. And I think the vaccine efficacy data for mpox isn't quite as great if you've just gotten one shot. And Bonnie, maybe Carlos, you can amplify and extend that conversation.
Well, so we just recommended, the outbreak recommendations for the mpox vaccine at ACIP, and we're actually trying to look at children. And there's a little bit of confusion, I think, about kids. People are talking about we don't want to give it routinely to children, and that's not the point of what we're trying to do. Is say that children should have routine access if they're going to be at high risk. Not that every child should get mpox vaccine, but I also want to point out that there's a huge outbreak going on in Central Africa right now. And it hasn't, we've only had 4 cases of those clade 1s, clade 1A and clade 1B. But when I was in Zimbabwe last year, it was starting to spread across Central Africa. People were very worried because the lack of surveillance in the areas, it's a hit in DR Congo and places where there's just almost no surveillance, no primary care. I think we talked about this before. And so we're very lucky right now that we haven't seen it spread out, but there have been 4 cases. And we're trying to make sure that they get vaccine in those parts of the world. And actually, there are people working from the US on that emergency response now, fortunately. But we just need to make sure that we are aware here of that. And of course, we just want to reemphasize to your point, Carlos, that the STOMP trial was very disappointingly sad and didn't work. And I was on that DSMB, and we were just very sad that we still need another drug to treat mpox, but there's a vaccine, and the first dose doesn't work well, but it's better than no dose. And then we want those people to come in and get their second dose.
Yeah, I think, again, you emphasized a very important point. The vaccine is not great, but it's sure better than the treatment. And Bonnie, you mentioned the STOMP trial, but Peter, can you just remind people, if we're not familiar with different studies, we were all excited about tecovirimat, but there are now 2 studies showing that tecovirimat really doesn't make much of a difference.
Yeah, basically before the trials, there was some hope that tecovirimat would accelerate the improve outcomes basically with mpox, if given early, and there are a lot of anecdotal cases. And then there was the STOMP trial basically, and maybe if you went to CROI, people who've gone to CROI would have seen that reported, but it basically showed in a randomized, well done randomized control trial that there was no benefit in giving tecovirimat.
Yeah, and in addition to the STOMP trial, there was also the study done in the DRC, right? That,
the DR Congo study. That was called the PALM trial, I think.
The PALM trial. Yeah, that's a PALM trial. Then again, emphasizing that, we need better antivirals. And I think those of us working who do HIV are I would say, are blessed to have a huge number of antivirals, and all of them, highly, highly effective. But that's not the case in most other viral diseases, right? That really is not the case, and really emphasizes the fact that at this point in time, in many viral infections, we have vaccines that are way better than the treatments. So before we go to pertussis, which is a bacteria, I just want to last August, CDC issued a HAN on Oropoucha virus. So what happened to that fizzle away? I haven't heard much about Oropoucha lately.
I think, well, Oropouche virus is actually named after a place in the country where I was born, actually, Trinidad and Tobago, where there's a town called
interesting.
Oropouche.
Huh.
It's a mosquito-borne virus. And the reason why it came to the attention of the CDC is because there was a traveler who came, I think, from Cuba, mainly to Florida and Texas. And there was, and then it spurred a lot of review of cases, and there were, in the order of tens of cases of people in the US. It wasn't acquired in the United States, but it really spoke to the outbreak of what was happening in South America, particularly Brazil, the Caribbean, and it was, thought to be it is an emerging infection affecting thousands of people this year. And the thing with Oropouche virus that made people sit up was that, like with Zika virus, there was a signal of causing fetal abnormalities and microencephalopathy in kids once people, had kids infected with, when they were infected and had kids with Oropouche virus. So again, one of these emerging infections that people are paying attention to.
Okay, well, we have a couple more minutes, so we will take a leave from
Let
focusing
me
on
just say,
viruses.
pertussis, we have an outbreak in California. It's not unexpected to have outbreaks. We had a huge outbreak in 2012. It led to the recommendation to vaccinate pregnant women to prevent disease in their babies. That's been highly effective. And that actually retroactively led to a FDA approval of the use of that. It had never been done before, but we were desperate in California because we were seeing horrible numbers of cases. So it's not unusual to see 3 to 5 year cycles. The pertussis vaccine used to be about 60% effective. The current vaccine is about 70 to 90% effective. It really depends on the population. And you don't get lifelong immunity. So it drops to about 30% after about 4 years. So in adults, a common saying is if you have a cough that lasts 2 weeks or more, you probably have pertussis.
Yeah, the 100-day cough.
Yeah.
But the other thing that's cool, Bonnie, is that I think a lot of people get tetanus shots every 10 years.
Yeah.
But they could get Tdap. And I know many ERs don't want to give Tdap, but for other reasons. But I think getting a pertussis with tetanus every 10 years is another reminder.
Yeah. Especially for healthcare workers, because we're going to catch it.
Absolutely. I think that's a good way to end our dialogue today. So I want to thank both of you for joining me again. This is really a very important thing to mention. We have Dr. Connie Benson saying, could you talk briefly about the recommendation to avoid chikungunya vaccine for those over the age of 60? What are the data for this recommendation? Bonnie, I'll turn it over to
So
you.
that just came out a couple days ago. As you know, ACIP recommended chikungunya, and CDC approved it a couple weeks ago in April. And now we're seeing some cardiac issues, and they're sorting through the data right now to make sure that that signal is real. But we know that chikungunya is a pretty reactogenic vaccine already. So I think they want to make sure that, again, getting chikungunya is no walk in the park either. So that's the problem, is what's the risk benefit here for travelers? And I think they're sorting through it right now, but that recommendation just came out and we'll have to take a look and see. And we hopefully in June, when we have our next meeting, we may have more data to go back and understand whether we need to restrict or provide more guardrails around use of the vaccine.
So do the ACIP meetings continue to be open so we can all watch them during COVID? It was like my favorite TV show.
Yeah, your favorite TV show. So everybody is virtual now. It used to be everyone was in person, and then during the pandemic, everyone was virtual. And now they were flying back, just the ACIP committee and the federal liaisons. But now everything is virtual for now anyway. We'll see what happens. Every day is a new and exciting surprise. So, but we are having a meeting in June.
And
Okay.
Carlos, my favorite TV show is The Last of Us because it features fungus. So
Yeah. Yikes. Another
thank you.
disease for which we need more medications.
Thank you very much for joining me today, and appreciate your wisdom and your advice. And I'm sure it was very helpful to our participants to hear what you had to say about this emerging viruses. This is one of many sessions that we have, and we'll continue to have them. We started during COVID, but I think they have been continued to be incredibly informative, and I really appreciate your participation. So can I have the next slide? I want to thank the IAS-USA, which sponsors this webinars, and the IAS does a lot many other things. We have a podcast going antiviral that our colleague Mike Sag hosts, and the latest episode 47, is talking about 40 years plus of HIV. IAS-USA will also be sponsoring a bacteriophage conference happening in October in Washington, D.C. So I encourage you to participate. And again, a lot of webinars, a lot of things happening. This is the topics in antiviral medicine. And the most recent issue of topics talks about sexually transmitted infections, recommendations for the management of many of them. And again, something we all have to stay up to date. And there's an upcoming webinar talking about update on prevention of infectious diseases for individual undertaken international traveler, where David Friedman, who's one of the national leading experts in travel medicine from the University of Alabama, and Dr. Judy Currier from the University of California, San Francisco will be hosting. So again, many educational activities coming from IAS-USA that you can all are welcome to participate, and they're all available for free. So thank you for joining us, and have a good day.